When we talk about racism as a public health crisis, it's not one or two things. There are no kind of magic bullets to fix it. We really are talking about an entire infrastructure, relationships with communities, just the way that we allocate resources, and then a whole, kind of historical burden of what has brought us to this moment. And so moving ahead in this pandemic, although we say, how can we correct inequities as we go? There is a recognition that we both have to do things in the moment as much as we can, but also that the important thing is that we come out of this with a recommitment to kind of rewiring our systems and societies so that this is not the kind of situation that we're going into for the next pandemic or other health crisis.
Good evening, and thank you for joining us. Welcome to your library. I'm David Leonard, president of the Boston Public Library and host of our Arc of History series. Tonight's conversation is part of our Arc of History Repairing America series and is presented in collaboration with the GBH Forum Network. Tonight, we are taking our second look at public health crises in America in this series, having recently looked at techniques to cope with the COVID-19 crisis. Tonight, we turn our attention to racism as a public health crisis. Here in Boston, our mayor has made the formal declaration of racism as a public health crisis, and members of our own city council have advocated for such a declaration. But we need to understand what this really means. Our guest tonight, Dr. Esther Chu, is a physician and popular health and science communicator. Using her expertise in public health, emergency care, substance abuse disorders, and women's health, Dr. Chu highlights the challenges to health equity in the 21st century. We'll also ask her about other topics that she may have faced in her work in this area. Repairing America as a theme provides us with the opportunity to engage with issues facing our country and to try to bend our arc of history a little more directly towards justice for all. It also gives us the opportunity to give voice to leaders, experts, and commentators who may not always have been afforded such opportunities. Tonight, we are pleased to be in conversation with Dr. Esther Chu. Dr. Chu, welcome. It's good to have you here. I think you're coming to us from the other coast, so we're doing this bi-coastal thing tonight. And if you would, I understand you have a framework that will help us really understand why we should look at racism through a public health lens. So I'll let you set up the conversation for us, and we'll dive into it.
Thank you so much. And I just appreciate the opportunity to be here and to be in conversation with you and with the attendees. I think, it is hard in this moment to think about racism and the way that it plays out in our health, in healthcare, and in public health without really thinking about the pandemic. So I do use the pandemic as kind of an illustrative example, not because that's the only health problem that we need to talk about for the next hour, but more it was such a stark example of how the structures that we have built, the practices that we have, the policies that we have, the resources that we have, simply the way that that public health and healthcare are reflected in all kinds of policies that don't even seem to be transparently about health, has really set us up for what happened in the pandemic. And I think there's probably a lot of awareness. I hope there's a lot of awareness at this point of how inequities in race and ethnicity were a predominant feature of this pandemic. So there are some health problems where we're kind of like, well, there's, a slightly increased odds ratio. This was much more like, okay, from space, if you look down, you could see some of these health disparities. They were not subtle. When we looked at the starkest thing, death rates, we found that Black Latino Americans, Indigenous Americans had death rates that were 2.7 times higher than white Americans. Pacific Islanders, 2.3 times higher, and just markedly higher rates of disease, hospitalizations, and deaths. And so, there was a big conversation about why this was. Was it a surprise? It was not a surprise. We have seen this in previous pandemics. Of course, we see it across many health problems. But what was playing out within the pandemic? And I think, and that's why, I have this kind of complicated slide in front of you, and we'll spend a little time walking through it. But I want people to understand that, we walked into this pandemic to begin with so many differences in social advantage based on race and ethnicity, which I'm focusing on today. But, you could add in or also consider a host of other identities that lead to vulnerability going into this pandemic. And then when you think about every single thing that determined your outcome specifically for this disease, for COVID-19, you think about where were there differences in exposure to the virus? And those are, you can see some examples. It's not comprehensive, but when we think about who was it that disproportionately had these essential workforce roles, or simply were in roles where there was just no work from home option, where, who disproportionately uses public transportation to go to work, or are sole wage earners, or don't have financial reserve, or live in housing situations or in congregate living facilities where the idea of isolating yourself or going into quarantine was simply not possible. And if you march through all those factors that contributed to how much exposure to virus you had once this reached global pandemic levels, there were stark racial and ethnic differences there. And then if you move on from there to, well, so then susceptibility to contracting disease, and once you have the disease severity, and there's a number of things too that are really disproportionate based on race and ethnicity, including burden of chronic diseases, which itself has to do with some of the baseline vulnerabilities I talked about. And then disparities in accessing care, in getting testing, in getting a diagnosis of COVID, and then receiving treatment quickly. And in an evidence-based manner. And once again, when we look at who has access to care, who lives near a well-functioning health center, who is insured, who is either is underinsured or lacks insurance. Also, who has the freedom to walk into a health center and have trust that they will be taken care of well, who faces both structural and individual biases when they go to seek testing or care. A lot of stark differences there, of course, based on race and ethnicity, of course, completely predating the pandemic, but total factors in the way that people were able to receive care. And we saw that play out in very specific ways when it came to timely testing, timely diagnosis, and then access to treatments. Often treatment is based on early testing and diagnosis. So that sort of became a circular thing. And then finally, very early on in the pandemic, we saw differences in enrollment in clinical trials. And that is something, again, completely echoes what has historically been true in any sort of medical and scientific research, huge disparities in representation in clinical trials. And we saw that if you looked at, for example, the early, the phase 1 Moderna vaccine trial, when they had their enrollment table, and if you haven't looked at it, please just go to that publication and look at their table that describes their patient population. And there are just a long string of zeros when you look at racial and ethnic minorities enrolled in that study. And I will tell you, phase 1 studies are often the most representative inclusive. So it made a lot of people concerned about what things would look like as we move through phase 2 and phase 3. And of course, if you're excluded from clinical trials, you are of course excluded from knowledge base, from best practices. But not only that, that exclusion feeds into responsiveness to therapies. So if you look at vaccine dissemination, a lot of the things that people are expressing are not just general hesitancy, but this idea that, that I wasn't considered when this medication was manufactured. People like me were not in the minds of the researchers when they put this medication together. And so specific exclusion is seen. It is felt by people on the consumer end. So enrollment in clinical trials in an equitable way, in a representative way, is so important. So, there are all these factors, and really the examples I give are just, a small sample in many, many elements that led to disparities across these 4 areas. And then you take the additive effects of all these disparities. And I think ultimately that is the explanation for unequal rates of illness and deaths that we saw in COVID, that we see in other diseases. And so, people will say, well, what is it that caused these racial and ethnic differences? And I mean, the answer is everything, the entire thing, every factor in the way that this virus spreads, manifests, and is deadly, has the potential to add to the kinds of inequities that we have documented over the course of this pandemic. So that's kind of the general framework I'm working through. When we talk about racism as a public health crisis, it's not 1 or 2 things. There are no kind of magic bullets to fix it. We really are talking about an entire infrastructure, relationships with communities, just the way that we allocate resources, and then a whole, kind of historical burden of what has brought us to this moment. And so moving ahead in this pandemic, although we say, how can we correct inequities as we go, there is a recognition that we both have to do things in the moment as much as we can, but also that the important thing is that we come out of this with a recommitment to kind of rewiring our systems and societies so that this is not the kind of situation that we're going into for the next pandemic or other health crisis.
So it seems like what the basic point here is that the deck was already stacked against people of color before the pandemic comes on the scene, and then in each of these disparity areas, it makes the situation incredibly worse.
That's exactly it. And also, I think the other thing is, in a crisis, if anyone has been attached to the healthcare or public health response to a crisis, you don't get innovative around equity in the moment. You fall back on old habits. So if our habits, the way that we execute, our response to a crisis, are not based in equity, we're not going to do it when we're stressed, when we have to act quickly, and when we have to, respond to an emerging threat. So we were simply not set up to execute equity in this moment, and it's entirely consistent with the way that health and public health operate at baseline in normal times.
Now, you on the left part of that chart, you're talking about all of the ways that people may be seen as different from each other. And given the topic tonight, you used both race and ethnicity. I'd like you to unpack that a little bit for us, for how both of those terms work in this context.
Yeah, I don't know that I have any magical way to unpack that, but I think, we can be a little bit more nuanced as we think through solutions than previous ways of thinking about race and ethnicity. I'll tell you, when I think of those terms, I think about all different aspects of it. It's like, it certainly is, a socially constructed identity. It's the way that other people see us and categorize us. It's your country of origin, what your primary language is, and your citizenship status. I think in the context of the kind of public health issues we're talking about, I think it really is the way that society categorizes you and your opportunity to resources, and to opportunity. And I'll say the other thing is, like, from a healthcare perspective, when we, right now, if you come into a hospital and we have these categories where, you have to put people into race and ethnicities, often those things are assigned to you at registration based on the assumptions of the registration person behind the counter, and there have been studies that show that what we identify you at actually is a little bit discrepant from what people report, and yet it determines all kinds of things. And so, for example, right now, a big controversy in healthcare is the use of race-based calculators for a number of things. Race-based calculators are, so for example, if you come in and I'm trying to figure out how good your kidney function is, you know? So we draw your blood and we send it off, and it comes back with some numbers. And the estimated glomerular filtration rate, which is kind of the measure of how well your kidneys are functioning, has a little race-based calculator. So it says, here's the number that it is if you're white, and here's the number it is if you're Black. and I could talk about this whole race-based calculator for like a full hour, but when people started thinking about it, we're like, but who even told you whether or not this person was Black? Did the patient tell you? Was there something in the chart that triggered it? And what if a person is 25% Black? Does 25% of that calculator apply? Or like, what is the basis for that? And so I think we're in the middle of kind of hopefully what will be a revolution in thinking about how we treat race and ethnicity in the context of our medical care, and our policies and our procedures. There's like, easily a dozen examples of that kind of thing across medicine that we don't justify very well, that has huge public health impact because we are systematically applying a calculator when we don't even understand the category or the categorization of race that leads to that sort of thing.
Where it came from in terms of the analysis, but also who it should be applied to, if at all.
And even what the underlying rationale for it is. I mean, what is the biologic basis for assuming that is okay for a Black person to have a slightly different creatinine level? There are a lot of racist assumptions underneath it. It's something that we have unquestionably applied for many decades.
Which to your earlier point would be, well, we're taking what is essentially a socially constructed measure and treating it as if it were a biologically connected indicator. Right. And if that's not the essence of racism in some way, I don't know what is.
I think that's exactly it. And I will say, we're not very fluent in this. So, I read a lot of grant applications and papers in the course of my job as a researcher. And I will say in the same paper, in the same grant, somebody will talk about race as a biological construct or as a genetic or as an ancestral construct, and then also refer to it in a framework that assumes that it is a social construct. So I think our precision around these terms is all over the map, and is certainly part of the problem.
So does that give us cause for concern then, if we're taking something that racism as a social ill or a challenge when it comes to access to opportunity or inclusion or economic progress, but then trying to use it as a measure of health indicators or health outcomes, because that seems to be potentially a double-edged sword as well.
Yeah, I totally agree. And I think we just need precision, which we don't have. I mean, we use race in all kinds of crazy, flexible ways. And I honestly think most often what we're measuring is the impact of racism, but we're afraid to say that. When we say things like this group has a different health outcome for diabetes, for kidney disease, for whatever it is, and we say it appears to be linked to race. Then we say, so it is a risk factor to be Hispanic and Latino. We say as if it's somehow like a deficiency that you brought with you. What a different frame to say. This appears to be an impact of racism, and we need to figure out how racism actually played a role there. I think that's usually how we're thinking about it. And then there are other things that are an impact of racism, but in a very specific way that has to do with, I guess a biologic feature, but like what I'm thinking of is our pulse oximeters, which kind of became a big news story over the past couple of months because of how important they are in COVID care. But pulse oximeters estimate the amount of partial pressure of oxygen you have in your blood, and we use them to categorize how severe your COVID is, because it's primarily a respiratory illness. And so, if you are oxygenating at a certain level, you'll go home. And with the same symptoms, you're oxygenating a few points lower, and you will come into the hospital. That's how we triage patients in the emergency department. It turns out that somebody did a study where they looked at the pulse oximeter and also drew blood at the same time to get a direct measurement of oxygen in your blood. And they found that if you're darker skinned, there's a systematic error, it seems, often, So not 100%, but there is a tendency for the pulse oximeter to estimate higher than you are. So you can imagine you have a Black patient and a white patient, and then somebody in the between, me, or somebody who's Hispanic in between. The measurement has kind of a continuum. It's a little less accurate as your skin tone gets darker. And so when we're thinking about why were there these disparities in outcomes, just that little margin of error based on skin tone is something that that played out in really stark ways. And I think, when you uncover what's underneath that, it goes back to, who do we enroll in studies? Who do we test devices on before they go out to the FDA? So that has it kind of like, it is racism, but is also based on, something that we can identify and reverse fairly easily.
Should we not have standards for a level of inclusion for these kind of, for clinical trials in one example, and for device standard submission to the FDA or other authorizing body?
Well, that's part of the fascinating thing about this. We should have standards, and we kind of do. So if you submit a grant application, say to the NIH for your clinical studies, they ask for an enrollment table, and they want to know that the enrollment table is inclusive. If it's not inclusive, they want to know why. So, I could have a study where I have no men, and I need to justify that. And I can say, well, this is a study about pregnancy, so I'm not including men, and that's a rationale. But generally, they expect to see representation across gender, across racial and ethnic groups. So you put in this nice table. It is representative. Sometimes you'll say, I'm going to oversample from groups, from minority groups, because they're chronically underrepresented in clinical trials. But the really interesting thing is that no one follows up on that. So I could put in this beautiful enrollment table, and then I do my study and I include actually nothing close to my original enrollment table. And there is no accountability for following through. And so this is where we can put all these beautiful policies in place. But if there's no accountability, if there's no penalty for not following through on inclusive research, how do we make progress at some level? And that's where it's an embedded problem that I actually think many stakeholders have a role in reinforcing these things and making it more than just an idealized enrollment table, actually making you follow through with your targets or having to explain why publicly,
without accountability, how else can we make progress on this particular front? Otherwise, the standards are not really standards. They don't have meaning behind them.
Accountability and also metrics. What was really interesting over the course of the pandemic, and I think again echoes a lot of things that play out in our regular lives pre-pandemic, is that we had actually such limited data. So it took, we were officially a global pandemic in late winter, early spring last year, right? And initially there was, yeah, that's right, it was an anniversary a week ago. It's been a long year. Initially there were just a handful of states that were releasing data by race and ethnicity. So we had age data pretty quickly, but race and ethnicity, and it really took to the summer until the majority of US states had released case rates broken down by race and ethnicity. And of course, every time that we got data, the disparity was more pronounced. But why did it take so long? Right now, as we're tracking vaccine distribution, many states, I actually think the majority of states right now are still not releasing vaccine distribution by race and ethnicity. We have it for a handful of states and for a handful of municipalities on top of that. But it is not a rule. Even knowing what has happened over the past year, it is not yet a rule, an assumption that we have vaccine distribution information by race and ethnicity. So it's like, what is our commitment to righting some of the inequities that have played out over the past year? You kind of have to wonder when we don't even have data and we're not clearly tracking or releasing data for public accountability.
And as I understand, one of the principles for vaccine eligibility is in part to give it to, or make it available to those who are most at risk, either by whichever health condition is indicated, or perhaps by the workplace activities that may increase exposure. I think that's probably two of the bars on that chart that we had at the start of the conversation tonight.
Yeah.
So my question is going to be, if you're saying that people of color are more susceptible because of all of the reasons that you talked about, should we not be exceeding the numbers that are in the population as a whole for vaccine distribution, rather than just trying to meet what is in the population?
Yeah, it's complicated. I mean, ideally, you would think, since vaccine offers protection, and we want to try to reverse course in communities that have been hit the hardest. Ideally, we would identify what those communities are, and vaccine distribution would be prioritized to those communities. I mean, I think as a general concept, people agree to that. But when it comes to execution, how do you do that? And there are, it's not just race and ethnicity. There are groups defined by other factors, as you alluded to. Age is a huge one. We want to get to our elders. We want to get to frontline healthcare workers. And then people with chronic conditions, which chronic conditions, how do you verify that you have those conditions, and then it kind of all breaks down from there. And I think states, we're actually in a really interesting moment in the pandemic, because every state is taking a slightly different approach to equitable distribution of vaccine. It's like that, when you're talking about evolution, there are these times in the history of the Earth where there's just kind of an explosion of different species. We're having kind of this explosion of different species of approach to equity, from very little acknowledgement that there is an equity based on race and ethnicity to, a lot of debate about what it means to distribute equitably. Some people say adjust the age parameters if you're, say, Black, Hispanic, or Indigenous, so that you can be 10 years younger than the other age category. Some states are saying there's an X percentage allocation to communities hit the hardest, and we will define those communities by, say, something like a social vulnerability index, which incorporates race, and also looks at how much there's a new COVID specific social vulnerability index, so identifies communities that have been particularly vulnerable specific to this pandemic. And so other people say, well, there should be an allocation, say, for Black communities, where death rates have been 5 or 6 times that of neighboring counties or cities. And so there are lots of different ways to do it. Some people think, if you just go to FQHCs, that will kind of naturally balance things out, or distribute to pharmacies, because pharmacies are, overrepresented in actually communities of color. There are a lot of different philosophies about how to do it, but there's not a consistent way. And I do think there's a lot to be said for a lot of different ways of doing things that fit an individual community. But I also think there's a lot of uncertainty about how you correct as you go. And the last thing I'll say in this vein is just that when you have been distributing resources in a really inequitable way, starting with testing, personal protective equipment, medications, everything all along the way, then all of a sudden you show up and you want to give one resource, like that is not, right. That is not a move that that is automatically trusted. And I don't love the word trust. It implies that it's something that should be there that's not, and sometimes it removes culpability, because I think it's not like trust, it's like earned trust. We have no earned trust as like a as an institution of healthcare. But I think it can be viewed with a lot of suspicion to all of a sudden show up with one thing when really we've neglected entire communities for an entire year.
And I think earlier on you were suggesting some of this is impacting I'll use the word trust again here, trust in the vaccine or in getting the vaccine, whether it's because, I'm not sure people like quote unquote, I'm not sure people like me were, tested for, or in the clinical trial, or the history of, I think abhorrent behavior in terms of how vaccine and tests and healthcare were performed on populations. So, how do you get beyond that? Part of it is availability, but part of it is the trust and education and information and encouragement.
Yeah, I don't think you build trust in the moment,
Right.
and because it's more than historical. It's actual lived experiences. over the past year and well before that. How do you repair a relationship in a moment? I mean, and the work when you look at, for example, the leadership boards of the major vaccine manufacturers, that's all you need to do. Like if you were somebody, you're like, who are these people? And you just pulled up the leadership boards.
Yeah.
They're not diverse. If you look at the research teams at the ivory tower institutions where many of these vaccines were developed, at least, you know, in the especially early trials, you were like, this doesn't feel like these people would represent me. It's like, so, you know, it goes into even our scientific and research workforces and leadership bodies and boards and, you know, and over into industry. And, you know, there's so much that just cannot be fixed in a moment. I was going to share out to the audience an op-ed by Dr. Rhea Boyd that appeared in the New York Times on last Friday. Mm-hmm. She's just a very pediatrician and someone who's really thoughtful about race and healthcare. Mm-hmm. But, you know, it's entitled, oh my gosh, I can't remember the title, but it basically says it's not about hesitancy. You know, the issue is not hesitancy. And it's like, it's not that hesitancy isn't there and that we, you know, that we don't need to address it, but I think that, you know, it's like if you are saying hesitancy, lack of trust and all this stuff, and then you're also not making vaccine available, it's like, first of all, how much trust is that going to engender? But second of all, it's like, you know, I don't know that having hesitancy is actually a bad thing or is actually the thing. I mean, people can always need more information or have lots of questions, and those things are, you know, we should make readily available. But, you know, there's data that show in some states, you know, like the most hesitant person is older white men or something like that. And then when you look at the vaccine rates, they're fine. So it's like, even though they may be ideologically suspicious or whatever, when it becomes available, people seem like they're taking it. So I just think that the hesitancy issue can be a huge excuse for not doing what we need to do, which is actually simply get the vaccine out to community groups that know how to distribute it, that are, you know, and know how to get the word around and are really getting the job done over the course of the pandemic.
And our production team has posted the link in the chat for viewers to that article. And I believe the title is Black People Need Better Vaccine Access, Not Better Vaccine Attitudes.
Yeah.
There we go.
Thank you.
As a layperson, when I think of medicine, basic medicine, I think of diagnose and treat and then prevent. So if we take that very simple approach and apply that to public health and to racism. So you've provided a diagnosis of our society in terms of looking at racism as a public health emergency. How do we treat? How do we prevent it from getting worse or from occurring again?
Yeah. A number of things. I mean, first of all, I think we can't fix it in our current systems. It's very difficult to fix it in current systems. And to use the public health framework, you know, it is so much harder to do secondary prevention, to kind of address a disease that has already manifested, than to do primary prevention, which is to keep it from manifesting in the first place. And so, you know, are we going to, like, you know, raise every healthcare institution down to the bricks and, you know, foundation and start over? We're not going to. But I think our best hope is probably, as new institutions emerge, actually really thinking from the ground up, what does equity mean? And I think, you know, there are a lot of ways in which healthcare, you know, of the 21st century will not be bound by four walls. You know, it really will be, I think healthcare will be a continuum of care, and the lines between traditional healthcare and public health will be blurred. Mm-hmm. And I think we really need to think, how do we invest in our communities? How do we insert health equity in actually all of our policies? Because environmental policy actually has a ton to do with healthcare. Our ideas about transportation have a lot to do with healthcare. Of course, housing, huge, employment opportunities, education, and the funding of education. All these things have so much to do with healthcare, and we've been really siloed in the way that we think about it. So I think health is in everything. So we need health equity policies in everything. So I think, and I'm seeing hints of this in the Biden administration, and just the way that people are starting to acknowledge that there are health implications, at least in these decisions that we make, and that those actually feed back into how people not just survive but thrive, and that those things really break down based on race and ethnicity.
So is part of it expanding what we mean by health as well, that it's not just traditional biological or physical health or even mental health, but there's a broader understanding implicit in that analysis?
Yeah, I really think so. And I think it really challenges the boundaries we think we have in healthcare. I have a friend who is about to come out with what I think will be a landmark paper about a concept she calls bounded justice. And part of her thesis is that, you could be a healthcare institution, even a public health body that has like the most pristine policies related to health equity ever, you could say, I'm going to have a new policy that actually like corrects inequities related to race. Like, so let's say in my hospital, I'm going to set up a vaccine policy that that on the face of it means that everyone who comes to us, that, you have triple the opportunity for the vaccine if your community has been hit 3 times as hard. So that means there's a huge prioritization for Black patients who come in, for Hispanic patients. But so we'll do that and we'll feel great about ourselves. And we will not spend a second thinking about all the barriers that prevent people from the community even coming to receive that benefit. And that is just kind of the way that we tend to think, is that we are in our bubble. There's this like perfect idea of equity, but we haven't thought expansively enough about the, even like providing inroads to that equitable policy. And so, yes, we need to think a lot more about, person's entire lifespan, and the many ways in which they interact with formal healthcare or bodies of public health, and think a lot about, think outside of our traditional frameworks. I think the other part of it too is that goes back to, you can have the best policies in the world. I think, we still are so inequitable in the way that we build our healthcare workforce. We have reached total stasis when it comes to, for example, the percentage of Black physicians we have, Hispanic physicians. And, we see that health outcomes improve when there is more concordant care, or simply when you have a more diverse healthcare workforce. And the same thing is globally true for public health. When we have leaders who influence public health who come from diverse backgrounds, outcomes for everybody tend to improve because they think about everybody. They're much more inclusive in their policy making. And so I think, we have clear workforce segregation where the decision makers in healthcare, and actually in all kinds of scientific fields, tend to be pretty homogeneous.
Yeah.
And I think, again, like, I can write beautiful policies and procedures, and as long as we don't change the face of healthcare, of public health, and the leadership, people who really can drive decisions, I just think our capacity for real change for different frameworks and priorities is severely limited.
Now, across the course of the last year in particular, especially following the violent killing of George Floyd, and a list of names that's really now much too long to list, one hopes there's an emergence of an appetite for, really dealing with some of the systemic racism that exists in our society. For people of color, this is not a new phenomenon. By one read, we could say this is a 400-year-old problem that we're trying to grapple with in this country. Is that appetite for change showing up in the healthcare industry that you work in as well?
It's hard to tell. And I think that's the question. I mean, everybody made beautiful statements
Right.
last summer. I thought they were lovely. They seemed very heartfelt. Are those connected to action? And what are the metrics by which we judge success following those statements? I certainly see a lot of people developing these new roles, equity roles in their hospitals and their departments. I have one of them, but it's I think time will tell, and I think we really need to start by saying, what does it look like for an institution to be anti-racist? How comprehensive are your efforts? And then I think importantly, what resources are you putting towards it? Because I think people expect this work to happen on the backs of volunteers. And I will tell you, I don't know a single person in healthcare who's Black or brown who has not been completely overtaxed in this time. And if you're wondering why there's an Asian person here talking about, health disparities primarily affecting Black, Indigenous, Latino people, and Pacific Islanders, it's because we cannot ask the teeny tiny percent of Black, Latino, and Indigenous doctors to carry the load right now. But certainly I think all the time about my own privilege as an Asian American in healthcare, and what role somebody like me can play over time in a sustained, invested way, not just lip service, not just helping write these wonderful statements that don't connect to anything, but with humility, really thinking about, am I fundamentally committed to the problem here? And the problem is not one of, the problem is really tied to our ultimate mission, which is literal lives. Who gets to live? Who gets to live longer? Who gets to live better? Who gets to live to their full potential? And if we are sincerely committed to that, then it means that, everybody needs to be committed in a way that really centers communities, but, allows us all to put some labor towards labor, resources, everything that this anti-racist movement needs.
And we haven't yet talked about differences among races or among different communities of color, which I think we could spend hours on as well. But I also want to have you comment on the fact that because of the association of COVID-19 with China, we have this anti-Asian American set of behaviors and characteristics that has reemerged as well.
Yeah. Yeah. Thank you for asking about this. It's it is so profound. The behaviors, I think the attitudes maybe were always there, but people are so emboldened in this moment. And in my networks that are primarily Asian Americans, just the stories every single day, the stories, and just the way that people are afraid for their parents. I mean, early on in the pandemic, when face mask wearing was not yet standard public practice, I had a long conversation with my parents they were flying up. I think it was before travel restrictions, it was probably around March, and my mother wanted to wear her face mask. Which was like a totally reasonable thing to do. I mean, if you're in Asia, by the way, like my grandmother would put a face mask on me because she thought the air quality was bad that day. I mean, we love face masks, they just love them. But they often wore them when they thought they were coming down with something or when they traveled internationally. My mom was like, well, there's this coronavirus and I want to wear a face mask.
Good general public health thing to do.
I think I'm always going to wear one traveling now, but my grandmother would be proud. But we had this whole circle because I said of conversation, I was like, well, if you wear a face mask, people will assume that you're from China and they will assume that you've been exposed to coronavirus. And there's a lot of stigma in the United States around face masks. We associate that with sick people. We think that means you're on chemotherapy or that you're immunocompromised. And I said, and you're Asian, and we had to go back and forth about what was worse, them feeling a little bit less protected and being exposed, or potentially having something racist happen to them while they traveled, which has happened to them before, independent of the coronavirus. We've had people be really aggressive towards my parents. we ended up saying that it was better for them to wear face masks. But I was like, I felt so sad to have to worry about that, and that was really early on. And I think since then the anti-Asian sentiment has been extremely, it seems like it's just been a constant issue, and really escalated to so much overt violence against Asian Americans in public, and particularly against our elderly, which those incidents are just so shocking and just so sad. It's like to take the most vulnerable people. And then, there are ways in which, and of course, like, being Asian is Asian American is not a monolith. There are lots of, it's just as you alluded to, when we talk about race and ethnicity, the conversation tends to be so, you know, kind of rough strokes, like just like really broad strokes for entire groups that have totally different ancestry, culture, language, and everything, so like so many different subgroups. But I will say, part of really thinking about race and ethnicity is understanding that that there are also ways in which being Asian American, specifically Asian Americans and not Pacific Islander, but being Asian American has been such a privilege during this pandemic. So yes, there has been a lot of anti-Asian rhetoric, beliefs, and actual violence. But at the same time, if you look at death rates, really the lowest of all groups were Asian Americans. So Pacific Islanders, I said, about 2.3 times deaths compared to white Americans, but Asian Americans, to peel away from Pacific Islanders, actually have had the lowest death rates, and they have the highest receptivity to vaccines. So I think over 80% of Asian Americans have polled out saying that they would be willing to take the vaccine. And it's kind of what I've observed culturally, even across political spectrum among Asian Americans that I know. And so, it's a kind of a complex thing, but I'd say there are definitely ways in which I appreciate the privilege of being Asian American and do not want to, I guess, overstate the hardship of this time because of that.
I'm going to turn to questions from our audience in a moment. We're also in National Women History Month as a country. So I think I'd just like to ask you if there are gender differences to this whole analysis that we should be drawing out or keeping in mind also.
Yeah, I think we really became aware in this moment of how women make up the majority of our essential workforce, particularly women of color. And what we experienced this year was a crisis in caregiving, because women have, compared to other countries, women in the United States have very little support for their responsibilities for children or for other family members. And they bear the brunt of those roles at home, and then they bear the brunt of essential workforce roles at work. And yet they are also most likely to have instability of jobs, to not have financial reserve, to not have sick leave, to not have the kinds of things of supports that allow you to do your at-home roles more. And there was a recent poll done by care.com, and they've said that something like 98% of employers have a plan to improve their caregiving policies and benefits going forward. 98%,
Wow.
some kind of, at the expense of other things. And they gave some examples, like maybe fewer free lunches at work, maybe fewer like commuter points or benefits, but really going to shift resources towards caregiving. And I think that will be a sustained thing, because I think we really got caught with our pants down in the ways that the workplace is not sustainable for women.
Well, to get 98% of anything to agree to do something is kind of an achievement. So there must be something there for sure.
For sure.
So if I'm pronouncing this person's name correctly, Zayad is concerned about the plethora of misinformation that's being spread. How do we address it, and in particular help build trust in communities of color?
Yeah, again, building trust, such a hard thing to do in the moment. I would say the silver lining is that, you're totally right about not just misinformation, but disinformation. In other words, bad information put out there maliciously and on purpose is the things that we need to combat. And something that we really learned in this time is how, I would say, healthcare, public health in general, communicating was a steep learning curve for all of us. And, you should know that for most health professional schools, we get exactly zero training on public health messaging. And I think that's going to change because we are learning it in the moment. And all I can say is that it is there's a need for constant sustained effort against misinformation, and just holding standards, like knowing where information comes from, being able to cite it, being able to educate on a meta level. So not just here's what we know about vaccine, but here's how scientists think and why we appear to change our minds. We're not changing our minds. We are adjusting our assessment based on new information coming out. Without explaining that sort of thing, then people think that scientists are super flighty, that you thought one thing in March and you thought something totally different in October. And why is that? Were you not reliable? Because I think in other industries, there's something towards about steadiness, consistency of messaging. For a novel disease, it was actually important that the messaging changed, but we weren't nimble around that. So I think there's a huge information void. With regard to addressing communities of color, there are a lot of really great efforts, specifically around not persuading, but hosting engaging conversations that really bring the tough questions up and having reliable messengers there to answer it. So something else we'll put in the chat is a new series released by the Kaiser Family Foundation. It's called The Conversation. And it is the comedian Kamau Bell hosting a conversation with doctors, nurses, and scientists who are all Black, for Black people, by Black people. There's an opening video that is extremely interesting, engaging, and even funny. But behind that, on their website, are 50 different videos addressing different aspects of vaccines for every kind of question that people may have, even really, I think questions that people might feel uncomfortable asking. They really try to get to every kind of concern. So just a wealth of information. And I think it is important that we put a lot of resources to direct conversations happening on the ground, between, among and within trusted communities.
This next question is really about the healthcare profession and some of the differences in opinion. So let me read Brandon's question. As a public health professional, an aspiring EM doc, says he loves your work, I have trouble explaining to my colleagues how racism is the root of the disparities and not some biological basis to race. For some, namely older white clinicians, believe to be true. So I think we touched on a part of this a little bit earlier in the conversation, but it's yeah. So I'll let the question stand.
Well, congratulations on choosing the best medical specialty. And I do think there is a huge void, so I'm talking to you, David, in this setting, and to all of you who have attended, I'm sure many of whom I'm just speaking to the choir. And I think, sometimes when we really get into this work around race and ethnicity, we assume that there are some basic assumptions that people have, we assume that we're on the same page, that like you all kind of know that racism has a profound impact on people's health. And then I'll go into some random meeting, with a research team, and I'll realize that actually there is no such presumption in that particular room. And that people really can live in bubbles of complete awareness about these things. And I think there is, and I hate to put more work on people, but I think there is really an obligation of people to do that education role, particularly when you are not of a group experiencing it, because you don't have the baseline exhaustion. So, I take it upon myself, always try to amplify the good work that people of color are doing. If they are putting out something that talks frankly about racism and 100 people saw it, let's make it our personal responsibility to pass it along to colleagues, to make 1,000 people see it, or tens of thousands of people see it. So I really try to amplify people who are spending their precious time educating them, but also take a role in that education myself. And it is exhausting. You are never done. No matter what, somebody in that room will be starting from Racism 101, where they are unaware that is a problem because they don't see color or whatever wild thing they want to say. Didn't racism end in the 1960s? All those kind of things. And so I wish I could say it's easy or there's like a single thing. I think it's a lot of us being really consistent about writing and talking and framing things and just like correcting people in the moment. And it is hard when you're a pre-med, a student, a resident. I think, you know, really those of us who are senior need to take up that mantle and set the example, and create lots of forums where we can push these concepts forward.
And to be, if you agree with me, I mean, part of this is the work that we as white people have to do on this topic to learn, and maybe we don't and can never have the same lived experience, but maybe we can learn the right vocabulary, and maybe we can learn the right language to engage in these discussions, even if they're stumbling and we'll make mistakes. And you know, I happen to believe I'd rather make the mistake and be corrected and learn than not to have tried at all.
I mean, I love that you say language, because it really is like becoming fluent in something.
Mm.
And I, you know, I consider myself kind of white adjacent in my privilege, and I say I can't even think of a week or sometimes even a day where I don't make a mistake. You know, in something that I say, the way that I frame it, assumption I made, a microaggression that I do. You know, there's no perfect people here, but I think just like learning a foreign language, the less you practice because you're anxious about you know, the conversation, it feels uncomfortable, so I'm not even going to try. The less that you get good. Like the way to get good, the path to being anywhere near fluent in this language that of the conversation that we're having is to make a ton of mistakes, you know, right? And do the adult learning thing of being willing to make mistakes under the observation of somebody else, receive feedback, and instead of getting defensive and avoidant, actually having humility. And so you know, I think there's like, you know, several times a week where I'm like, I get that feeling on the inside where you just want to be super defensive, and I just kind of try to breathe through it and figure out, you know, oh boy, I got to really absorb that lesson, because that term is a loaded term and causes a lot of pain to people of a certain racial or ethnic group. I do it all the time, and I think we all have to sign up for that kind of discomfort.
I mean, clearly one hopes never to make such a big mistake that it is truly offensive, but there we are.
There we are. It happens for sure.
Deborah, and this is an area I don't know much about, so I'll read the question and see if you can respond. Deborah's wondering about farmers and their roles in our health. Black farmers have been disadvantaged by USDA policies for generations. Can you speak to the ways the pressures on the next generation of farmers, many of them BIPOC, affect the ability of all of us to grow and buy healthy food? I think there's layers to this question. Because most farmers of all ages have to work another job to actually support themselves. So there's health, there's how we produce food, there's disadvantage to Black farmers in particular, all loaded in that question.
There are so many things loaded into the question, and I am not sure I can give a definitive answer, but I will say, you know, I'm out here on the West Coast where a lot of the COVID disparities played out through agricultural workers. And yet they were not in, you know, in many states out here, they're not prioritized in PPE. You know, basically had zero capacity for social distancing or isolation after a confirmed, you know, or quarantine after a high risk exposure or a confirmed case. And then, you know, low prioritization for vaccine distribution. And so it's really made me aware, particularly how that exacerbates racial and ethnic disparities. And also how I think this industry, like many other industries, people think of, I guess, like, you know, we often have kind of images in our head about who owns an industry. I'm in Oregon, so I think of the cannabis industry, and which is kind of a farming industry. But you know, when you think about who bears the risks of that industry versus who benefits from it, you know, often the resources, you know, the contracts, you know, who does business with you, all those things are so driven by race and ethnicity, And I think this is where, yeah, I mean, sorry, there's so many aspects to this. I'm just not sure where to go. But I do think that part of our systemic structural awareness of racism has to think of every single um, point along a whole chain of, of resources or of processes, and thinking about where inequity it is. So, I think in the hospital we often think, how do we behave with regard to our vendors? So like every time we order lunch, are our resources going to Black and minority owned businesses in our community? And, that's a kind of like biopsy, but what if we go upstream from that? It's like, who is making the food? Who has contracts with, our major food producers from their farms? And I think that there's equity in everything. And I hope that everything that we've been talking about extends to things like food, agriculture, and just kind of, everywhere that humans plug into a process for some service or good that we receive.
Yeah, and
anyway,
this part of the conversation plugs also further into equity among food access in general, as well as environmental and climate concerns, as we hinted at earlier. The image that has popped into my head in response to this question is the terrible stories coming out of the meatpacking industry, in particular the slaughterhouses that we saw across the Midwest. And those are certainly areas where the exposure to COVID-19, the coronavirus, was very high, and that those are also industries mostly populated by people of color.
Yeah, I really love that observation. And I was thinking of something, a scholar that I work with was talking about how hard Native populations were being hit and what a loss that was, not just to Native communities, but to everyone, because Native communities have a lot to tell us about a respectful relationship with our environment, with
Sure.
preservation of our lands, and how much is lost that has to do with health for everybody. And I think, I love that. I wish I had more time to kind of unpack the question around Black farmers, but I do think too, when we look for solutions, solutions should not come from the outside; they should come from the inside. And so to the extent that we look at nutrition, food deserts, ways to improve, some of the racial and ethnic disparities that play out through food and nutrition. Black farmers, the idea of Black farmers being part of that, being driving that solution, and really having different frames and being supported in that work make a lot of sense.
Beth asks, I've been working on outreach to Black communities with information on COVID-19 vaccine appointments and access, and a high percentage of people have stated they refuse to get it. This is back to the legitimate distrust of the medical system, and how do we help people get the resources they need?
I guess I would ask, where do people get trusted information, and can we put the vaccine in the hands of somebody else, where they may feel, where any community that you're targeting feels more comfortable getting information and making decisions there. It's like vaccines don't need to happen in health centers. They shouldn't actually,
Right.
they're not. They're happening in a lot of mass vaccination centers, but they're also happening in churches and community centers and apartment complexes in New York City. And so I think, I do think that health-based vaccine distribution mostly does outreach to people who have primary care providers and have some level of trust in that system. So I'm not sure your setting, but I think we need to, if one setting and one messenger and one delivery person doesn't work, then I think we need to relinquish that to somebody based in the communities that we're trying to reach, and just make sure the decision-making for that strategy comes from there.
This next question ties back into sorry, I just lost my place. Yes, this question goes back a little bit to the calculator that you were talking about earlier. And the question from Rosario, who works in the healthcare industry, is, do you know of ways that changes to the software we use can help address some of these racism issues? And I'm sure there are other pieces of software that are just as challenging as the calculator that you mentioned.
There are. I mean, there are clinical algorithms that can be removed from the EHR that we use, and there are so many of them, by the way. There's a C-section one, there's a pediatric fever workup one, there's all these race-based calculators. But I think a lot of our equipment is problematic. If you go into the ICU, some of the ventilators have a master and slave port. And apparently that is just very baked in across all kinds of equipment and computer programming and manuals that are printed. And it's not as simple as saying, we're going to rename those, because it is embedded in like the manufacturing process.
Mm-hmm.
And so I think we need to actually communicate to vendors of all kinds of equipment and software that is not acceptable, and we will shift to another vendor who makes a different choice.
Right. Why couldn't we call it a primary and secondary port?
Why not? To me, it seems very simple. And yet I'm told by people who work in computing and programming and machinery that those terms are not simple to change. And I am probably too limited to understand why. But I have not figured out a way to systematically remove that from healthcare. It's been there everywhere I've worked. I think, I mentioned the pulse oximetry problem before. And, that is, by the way, I'm sure a lot of people, if you are dark skinned at all and you have been in a bathroom that has an automatic sink or an automatic dryer, you have experienced the same thing, which is that product was not tested in different skin tones. It's not you or the way that you're moving your hand. It is actually your skin tone. Just go in the bathroom with a bunch of friends with different skin colors, and you can figure out if that's an issue in those machines. I've done it with a bunch of friends on purpose like that. It's like so hilarious. But I think, when people looked at those pulse oximeters, it's not every manufacturer. There are some manufacturers that had a broader, representation when they tested that product, and some that had none. And so, we can vote with our money and choose vendors selectively, be aware of the way that structural racism has crept into everything from the way we build our buildings to, all the machinery that we put in there. And so we can demand, if, anyone who's in charge of any sort of, decision making around purchasing has tremendous influence in actually sending messages to manufacturers and developers of these things about what is acceptable. So I do think it's one of those things where they need to have real market pressures to change, but this is something we can do as a community. We can start writing letters, we can start getting healthcare institutions, other organizations and people who are responsible for these things, pushing back and saying, you will not get money, this valuable contract, if these things are not changed.
Are you optimistic that we're going to learn from this experience and move forward in a positive way?
I am. I mean, we've never had a crisis like this. I don't actually think that collectively we have absorbed what it means to lose 500,000 people.
No.
Your brain is actually capped out. Because we haven't lived through, a wartime like that. We haven't lived through any sort of thing like that before. And I think what will come, right now we're all focused on getting to the end of this, and declaring the global pandemic over, on getting to herd immunity. I think there are so many like short-term things that our brains are just focused on, that school reopenings, all these things. There's just a lot of details to work out. And I think when we emerge from that, we're going to step back and we're going to realize the depth and breadth of this and what we have lost as a society.
Yeah.
Anyway,
even people who are functioning are in one way or another exhausted or numb, and so I don't know, when is the sigh of relief that for those of us who are still alive, that we go, we've made it, and then start to unpack what has transpired over the last 12 months.
I really think so. And, we have changed. Like, people who sell shoes have observed that there are a lot of wider feet now, because people haven't been squishing their feet into formal shoes or into regular workplace shoes. And so literally we have physically changed.
Huh.
And I'd like to think that our brains have changed, and that we are newly aware of things. I mean, between all the conversations around racism last year, and the pandemic and the way that it has played out, I like to think that our brains have spread too, have spread to now be inclusive of ideas, new insights around the way that our society is structured, and that's a permanent change, that we're not going to narrow up our brains again, by forcing them back into these like narrow constructs. Hopefully we've spread our perspective in these areas, and so that moving forward we're just incapable of acting in the ways that we did before. That's my hope. So I'm optimistic.
And that could be, all across all parts of society, not just around healthcare or around the racialized challenges that we have. There's this phrase "new normal" that was being used a lot, which a lot of people now are trying to reject because it feels off.
Right.
But what we return to, or what becomes the baseline going forward, I don't think anybody has a crystal ball. And yes, we've learned new patterns. This has been a year, so we've learned new patterns. But our ability to deny the reality that's right in front of us and protect ourselves also sometimes knows no bounds. There's one more question that's come in about medical schools, and perhaps you're familiar with some racist events that occurred in medical schools. And the basic question here is, are you aware of medical schools and training programs, what they're doing to address racism, perhaps so that the demographics of healthcare providers could better match the communities they serve?
Yeah, I mean, I think all medical schools right now are grappling with, first of all, revolutionizing their curricula, because it turns out that we don't even know how to have discussions or how to teach people about the impact of structural and individual racism. So I know that there are a lot of efforts to do that. And then also to make their environments feel welcoming. I don't love the term diversity. I don't even like the term inclusion, because it's like, if you're including people, who's still running the show? Who's still like in charge of the party, but you decided to include slightly different people. What I really like is just you walk in and you feel that you belong there. That's what you hope for everybody. And I know, schools are at least much more conscious than they were, but changing overnight is hard. And again, how do you change anything when the leadership structures, the decision makers are pretty much the same? And you can just look at, again, spend some time on websites, look at the leadership structure of almost every medical school, and it does not suggest that there's any radical change happening there. They're very traditional environments, most often compared to the military on a number of fronts in terms of like how traditional the environment is. So we like to say that we have, trailblazing science and kind of earth-shattering innovations in science, but that doesn't mean as organizations, our organizational structures and representation are as innovative or groundbreaking. And so I think every time we project out, when will we have say racial representation in across clinical fields in medicine that is proportional to the population? People always have these projections, and they're generally on the order of like hundreds of years. like feel good about what you're doing now and know it will benefit like some of your descendants. So it's like, if we continue at our current course, so either we really make big bold change, and I will say it has to be as upstream as we can go. So I often will turn down a talk from like a clinical department or even a medical school, but if I get a talk to a college, a high school, an elementary school, I never say no, because that's where we really need to change people's ideas of who goes into healthcare fields. I mean, you asked me to go to a preschool, I would never say no to a preschool, because people start developing images of who or what they can be very young, pre-kindergarten, clearly. And so I think this is many years of work in shifting people's understanding and getting rid of all the things that make healthcare so segregated in terms of roles that are that have power. I mean, I have a friend who said, if you want to see diversity in the hospital, take the elevator all the way down, and it will get more diverse the further down you go. And that is that is true in almost every hospital. That the roles that we give, it's not that there aren't people of color there, it's just that we have sharply segregated who goes into what roles. And if we want that to change, we need to set some really aggressive, targets, and figure out how to get there.
And make them intentional and
Yeah.
measure them and hold people accountable for moving the needle. I think even as a library is not a hospital, is not a healthcare center, but we're an institution, and so we know that even when our institutions are not perfect or we make mistakes, we have to continue doing the work and ensuring that the aggregate of movement is in the right direction, even if on occasion it's 2 steps forward and 1 step back.
Yeah, and the measurement thing is so key. I mean, it's very interesting. I give a lot of talks about diversity goals and whatever, positive culture for like a very diverse group of healthcare providers, all these things. And, I sometimes will ask people, well, what are your targets with regard to
Right.
diversity, inclusion, and equity? Because I see your statement, but I'm just curious because if we wanted to improve like diabetes care, we have so many targets. I mean, I have some like vitamin deficiencies, and my primary care, man, she has numbers that I need to reach, and I have to get my blood drawn every 3 months. And if I'm not there by the 12th week, she is on me, and she has dose adjustments. And it's like I am so, it's like I am experiencing the way that we tie healthcare goals to metrics right now, really personally. And then we come to things like this, where we're talking about diversity, inclusion, equity. And I'm like, so what are give me some numbers, any numbers, give me some percentage here. What are you aiming for? And when do you want to get there? And if you don't get there, what are you going to change? And like, we cannot talk in concrete terms. I think people are afraid of it. They have like sort of, a lot of fear around the word quotas and things like that, I think have really held us up. But it's like, I understand that there may be some frameworks you don't want to use, but if we don't articulate goals, how do we know that we got there or even that we're on our way, other than this kind of gut feeling? And so I think we need to, I think we really need to get specific with our goals in areas of equity in the way that we are about any other issue in healthcare.
And maybe diversity, equity, and inclusion are actually 3 different words that mean 3 different things, rather than a whole little buzzword phrase that
Right.
Is a way of checking the box.
Right. Maybe one of our goals could be get rid of some of those words.
There's a final comment that has come in. I'm just going to read it for you. Maybe have you react to that and offer you an opportunity for a closing comment about what we should be doing. As a pulmonary critical care doctor, this entire conversation, from the pandemic, spirometry, pulse ox testing, vaccination, is so profound. I've also read your articles on 7 things and 7 more things organizations should be doing to combat racism. Thank you so much for your insight, dedication, and perseverance.
I don't know what to say to that. Thank you so much. I really appreciate those comments, and just that something I wrote got your eyeballs. It's really an honor to hear that.
Esther, any closing words for our audience and how we continue to use the public health lens as a way of analyzing and dealing with the problem and crisis of systemic racism?
Yeah, I just I want to empower people to do something to help somebody get to vaccine, and then afterwards to commit to doing one thing that addresses equity in your sphere, whatever that is, in your neighborhood, in your workplace. I think if everybody did that, I just think the impact we could have would be enormous. And just thank you for being here and your attention and interest.
Dr. Chu, thank you again so much for joining us and sharing your thoughts and being in conversation. Thank you all for joining us and watching and listening along. And my thanks to our BPL production team, as well as our partners at the GBH Forum Network and our sponsors at the Lowell Institute. Until next time, please be well and be safe. Thank you for joining us.